Yes, sir.
Yes.
Recording in progress.
Okay. So today we are discussing high bleeding risk in patients undergoing PCI. So objectives are to define HBR in PCI patients, to discuss risk stratification and scoring systems, to outline challenges in balancing bleeding and ischemic risks, and to review strategies to optimize PCI outcomes in HBR patients. So we take a case scenario like a 79-year-old male, diabetic, hypertensive. He had GI bleed with DU ulcer in 2021, and now in 24 he presented with ECG diffuse dynamic STT changes with drops raised, diagnosed as NSTEMI with LVF. EF was 45%, and mitral regurgitation was there. HB was 8.8, serum iron was 30, EGFR was 38. So now ischemic versus bleeding risk. He has high risk of bleeding like age, bleeding prone lesion, history of prior bleeding, baseline ischemia, anemia, CKD and hypertension, and high risk of ischemic events like age, troponin positive, ACS, diffuse ST changes, LVF, CKD and diabetes. So why is this important? Because ischemia and bleeding, there is a balance of risk. Like we have to decide antithrombotic treatment, choice of drugs, drug dosing, treatment, all depend on patient's characteristics like age, sex, race, history of ischemia, clinical presentation, whether it is CCS or ACS, comorbidities like CKD, diabetes, PAD or heart failure, and co-medication, need of anticoagulation or various other drug interactions, and procedural aspect, whether PCI versus CABG, femoral versus radial access, invasive or conservative management. So the same factors predict bleeding as well as ischemic risk. So we have risk calculators available online, and predicting mortality in patients undergoing PCI. There is full model predictors like age, CVD, CLD, prior PCI, frailty, LVF, STEMI, female sex, PAD, CKD, diabetes, SPPs, aortic stenosis, and so on. So we have a shortcut bedside risk score calculator also, which includes age, CKD, various stages 3A, and different points for them, and salvage PCI, cardiogenic shock, CVI, emergency PCI, urgent PCI, and so on. So higher the risk score, higher is the mortality rate. So there is distribution of bleeding versus ischemic risk, sex difference in distribution, management, and outcome of combined ischemic bleeding risk. As we can see, there is more in female sex than male. So there are various ischemic risk scores like GRACE, GRACE 2, PARIS, DAPT, PRECISE DAPT, PRAISE, ABC, ACS ischemia starting from year 2006 to 2022. Some have only ischemic, calculated only ischemic events. Others have bleeding scores also. So coming to bleeding risk scores, there are many. REACH, Dutch ASA score, DAPT, PARIS, PRECISE DAPT, and BLEMAX. So how do we define high bleeding risk? It is defined as BARC 3 to 5 bleeding risk of more than 4% at 1 year, or a risk of an intracranial hemorrhage of more than 1% at 1 year. The cutoff of 4% for BARC 3 or 5 bleeding was based on consensus of a participants, taking into account that 1 year major bleeding rates in trials of DAPT after PCI, which largely excluded patients with at HBR, were less than 3%. Now, what is BARC scale? It has 5 types. Type 1, any bleeding that is not actionable. Type 2, any clinically overt or actionable site of bleeding. Type 3 has 3 types. Type A, any transfusion 3 to 5 gram hemoglobin drop. Type 3B, more than 5 gram hemoglobin drop requiring surgery or vasopressors. And type 3C, intracranial hemorrhage or intraocular bleed. Type 4, bleeding related to CABG or more than 5 minutes blood transfusion in 48 hours or more than 2-liter chest tube output in 24 hours. And type 5, likely fatal bleed not confirmed by autopsy, definite fatal bleeding confirmed by imaging or autopsy. So identification of HBR patients focus on ARC HBR definition. What is this academic research consortium and why it has been created? It's an informal collaboration between clinical experts, several academic organizations, with advisory participation of FDA and other regulatory bodies across continent. It was founded in 2006. The group first focused on key definitions for application in coronary stent trials, conducting a series of think tank meetings and publishing the consensus documents in peer-reviewed literature in 2007. Then a lot of new definitions and consensus documents have been created with the main objective to support the scientific community in understanding, managing, and treating the patients in best way. The outcomes are several consensus documents as clinical endpoints in coronary stent trials, a case of standardized definition. In 2011, standardized bleeding definitions for cardiovascular clinical trials. And in 2019, defining high bleeding risk in patients undergoing percutaneous coronary intervention, a consensus document from Academic Research Consortium for high bleeding risk. So why the need to identify HBR patients? In 2012, the estimation of HBR patients in daily practice was only 20% of total population. And in 2019, after ARC HBR definition creation, this estimation was updated to 40 to 45%. After the presentation of leaders-free primary endpoint due to consistent number of patients and to the need to optimize their treatment, the ARC decided to work on a specific tool able to identify HBR patients by reviewing the available clinical evidence and all bleeding scores presented in EuroPCR 2019. So before 2015, it was known that HBR patients exist, but they have never been studied properly in stent trials, especially after ESC DAPT storm in 2006. HBR patients can't tolerate 6 to 12 months DAPT. Hence, the consensus is no DES in HBR patient, go with BMS plus 1 month DAPT. But this wasn't a clinical validated indication. Then came leaders free. For the first time ever, a trial completely focused on all corner HBR patients, all treated with 1 month DAPT. With the leaders-free results, there was the beginning of understanding of HBR patients. Unfortunately, one trial and a subgroup analysis of HBR patients subgroup in GEOS weren't enough to understand who they are since the overall number of patients is low and moreover the patient characteristics considered were different in two trials. Then 2016 onwards, a dedicated task force, that is ARC-HBR, has been created with objective to standardize the criteria related to risk of bleeding in order to create a universal definition of HBR patients. Clear identification of HBR patient on binary way, that is yes or no, and identification based on standard criteria. Tool created based on literature review, major bleeding scores, and trials focused on HBR patients and clinical consensus. So before the creation of ARC HBR definition, they were identified based on main existing bleeding scores, few clinical data, but this was not enough to clearly identify them. Different criteria, 6 bleeding scores were there: REACH, Dutch ASA, DAPT, Paris, Precise Depth, Bleeding Max, and 3 RCTs, leaders free, senior, and GEOS subgroup. So all these were considered were different from one another. Different inclusion criteria and different kind of patients were included in each trial, resulting in very heterogeneous trials. So they took into consideration all these scores. All the above scores are predicting long-term bleeding risk in patient taking depth. Every score is considered different variables and only criteria present in all is advanced age, but the relative weights and age cutoff vary between scores. These scores have moderate accuracy for predicting bleeding and none of them have been validated in HBR patients. Only in Dutch ASA registry, proportion of HBR patients was 83. In all other studies, it was not more than 25%. So, role of leaders free in HBR patient identification. It started enrollment in 2012 and considered for scientific community the trial reference for HBR patients. The inclusion criteria list has been considered a good tool for reference for HBR patients. And for the ARC group, this trial is one of the broadly inclusive HBR criteria. And for this reason, this list has played an important role during ARC HBR definition designs. So these are comparing BMS as well as DCS, drug coating. So an app where the patient is defined HBR on yes or no basis. So this is available online. So focus on ARC HBR status. A criteria is defined major if the risk of bar 3 or 5 bleeding more than 4% and ICH more than 1%, and minor if bar 3 or 5 bleeding less than 4% and ICH less than 1%. So now what are these 12 criteria? Major, minor, or both major or minor. As we can see, aging, age more than 75, GFR less than 60, liver cirrhosis, cancer, anemia, platelets less than 1 lakh, prior cerebral pathology, bleeding diathesis, prior bleeding, chronic NSAID steroids use, long-term oral anticoagulants, and planned or recent surgery on DAPT or trauma. So 6 criteria are major, 2 are minor, and 4 criteria can be major or minor. So coming to criteria one by one, age more than 75, being elderly is considered minor criteria since they tend to have more comorbidities and coexisting risk factors for bleeding compared to younger patient. And GFR, severe or end stage chronic kidney disease, GFR less than 30 is considered major, and GFR 30 to 59 ml per minute is considered minor criteria. Liver cirrhosis, it's a major criteria since the bleeding risk in CLD may be related to impaired hemostasis or to a esophageal varices in presence of portal hypertension. Cancer, active malignancy is a major criteria and is defined as diagnosis within previous 12 months or ongoing active cancer treatment. Current cancer is associated with higher rates of in-hospital bleeding that can be caused by local invasion or by secondary systemic process or by cancer treatment. Then anemia, HB level less than 11 is considered major criteria. And however, 11 to 12.9 for men and 11 to 11.9 for women is considered minor criteria. Similarly, thrombocytopenia, moderate or severe baseline thrombocytopenia is considered a major criteria. Prior cerebral pathology, ischemic stroke, intracranial hemorrhage, or brain AV malformations, these are major criteria. And minor criteria, if any other ischemic stroke at any time, not only within 6 months, is minor criteria. And bleeding diathesis, major criteria is significant chronic bleeding diathesis, like in platelet dysfunction, wall bilirubin factor, clotting factor deficiencies. And prior bleeding, major if any prior non-ICH bleed in past 6 months, and minor criteria if first non-IC bleed between 6 to 12 months before PCI. So let's understand more about each criteria. Like next are iatrogenic. Chronic NSAIDs or steroids, long-term is considered minor criteria. Long-term oral anticoagulants are considered major criteria. And planned or recent surgery on DAPT or trauma, major criteria, any planned non-deferrable major surgery after PCI and any major surgery within 30 days before PCI. So focus on ARC HBR, why it is important. It helps physician to speak a common language and in taking decisions. How does ARC HBR applies to various trials focused on HBR patients? Like coming to leaders free, with no exclusion in comorbidities, anatomies, procedural requirements. Additional exclusions are enrollment at the index procedure, 1 month depth prescribed for all patients. So we can see there are 4 absolute major criteria: oral anticoagulant, surgery soon, anemia, and cancer, and 1 absolute minor criteria. 1 criteria that can be major or minor based on severity of disease, that is renal failure. All patients enrolled in leader-free family of trials and in Onyx 1 Global are true HBR, but also all comers. No patient was excluded in terms of comorbidities or patient complexity. All patients have received 1 month DAPT, also the most complex ones. We can see in Onyx 1 clear. So no ARC HBR criteria were excluded. Additional exclusions was patient not free from adverse events by the time of randomization, not included in the trial. Coming to senior, prior cerebral pathology and planned or recent surgery on DAPT. These 2 were exclusions. Additional exclusions, it is not all comer population since some comorbidities were treated differently and some complex patients were excluded. And ACS patient received 6-month DAPT and CABG patients. And in Evolve Short trial, long-term oral anticoagulant was excluded. Additional exclusions, it was not all comer population, STEMI and NSTEMI patient, left vein and osteal lesions in LAD, LCX, more than 3 lesions, or more than 2 major epicardial vessel involvement, CTOs, thrombotic lesions, complex bifurcations. Then Zines short DAPT, again, planned or recent surgery on DAPT or trauma was excluded. Additional exclusions was, it was not an all-comer trial, STEMI, left vein, arterial saphenous venous graft, CTO, PCI requiring overlapped stents, patient with more than 3 vessel, more than two lesions, bifurcations, all these were excluded. Then master DAPT trial, GFR less than 60 ml, and planned or recent surgery on DAPT. These two criteria were excluded. Additional exclusion, again, not an all-comer trial, ISR or stent thrombosis at index PCI, previous treatment with bioresorbable scaffold. So again, coming to these criteria, we have already discussed this. Now coming whether radial versus femoral, which anticoagulant, which device, which stent, and which DAPT strategy, and how long. So access whether radial or femoral, the present findings suggest that outcome of mortality or new Q wave MI and bar 3 or 5 bleeding were not significantly different between radial and femoral access in patients at low risk of bleeding, precise depth score less than 16. However, it is strongly favored radial access in patients at high bleeding risk. So influence a different type of bleeding during PCI on mortality. Excess side has only at odds ratio of 1.71. So major is intracranial bleeding with 22.71 odds ratio. Choice of anticoagulation. Comparison of 2 doses of UFH like 100 international unit per kg versus 140 international units per kg. So there is no difference in death, urgent revascularization. However, major bleeding was more in higher dose, and surprisingly, MI was also higher in higher dose. So recommendations for anticoagulation in different indications in current ACC, AHA, and ESC guidelines. So UFH is class 1 indication in all SCADs and STEMI in both ESC and ACC guidelines. Enoxaparin is mostly 2A and 2B. And fondaparinux only indicated in NSTEMI patients if used additional UFH during PCI. And bivalirudin again in patients with HIT and 2A in patients with high bleeding risk. Comparing bivalirudin and UFH with GP2B3A inhibitors in patients with non-STEMI undergoing PCI, as we can see that major bleeding and net adverse clinical events were lesser with bivalirudin in both ACUITY and SR-REACT4 trials. And heparin versus bivalirudin in HBR, again we can see that bivalirudin has lesser of MACE, major bleeding, and in Horizon, Euromex, and only in 1 or 2 trials like MACE is more with bivalirudin. So DES versus DCB. So drug-coated balloon for small coronary artery disease in patients with or without high-risk bleeding in basket small 2 trial. DCBs were similarly safe and effective in current generation DES in treatment of coronary arteries less than 3 mm, regardless of bleeding risk. In patients treated with DCB, there was a trend towards a reduction of severe bleeding events at 3 years. So in a meta-analysis of these 4 trials, basket small 2, Piccolo, Restore, SVD, and Bello, we can see pooled data of 3-year outcome. We can see all MACE, all-cause death, myocardial infarction, target lesion revascularization, and target vessel thrombosis, all favor drug-coated balloons. Coming to choice of stents. Several trials, polymer-free drug-coated coronary stents in patient at HBR, like in leaders-free trial. Polymer-based or polymer-free stent in high bleeding risk, Onyx 1. So BioFreedom was the device used, polymer and carrier-free drug-coated coronary stent system using drugs Biolimus A9. Similarly, in BioFreedom Ultra, again polymer and carrier-free drug-coated coronary stent system with BioLimus A9. So leaders-free ACS subgroup 2-year follow-up, as we can see. It was the first trial to demonstrate that an active stent, BioFreedom, can balance thrombotic and bleeding risk in HBR patients. Coming to another trial, that is Kamir Korea Acute Myocardial Registry. It shows trial of 13,000 patients, 3,300 excluded. Then we can see there was 31% relative risk reduction in biometric stent as compared to Zymes or Promus in death. And similarly, cardiac death, there was 41% relative risk reduction in biometrics versus Zymes and Promus. However, conflicting data of various stents, few are FDA labeled and CE marked like BioFreedom, Resolute Onyx, Synergy, and Zymes. And few are like BioFreedom is polymer and carrier free, or Zero Mission is bioresorbable polymer stent. Some are durable polymer stent like Onyx. Supraflex is biodegradable stent. Synergy bioabsorbable. And so in all those different drugs like biolimus, sirolimus, soterolimus, and different polymers, and it's a confusing slide relatively. But as we can see, in various trials like Leaders Free in 2015, BioFreedom versus BMS. As compared to BMS, like in senior also, so these are superior ones, DES. And if we compare Onyx with BioFreedom, again non-inferior, or Zero Mission with Resolute Onyx, again non-inferior, Ultimaster with Supraflex Cruise, non-inferior, and Ultimaster. And so DAPT strategy and duration. In 1980, aspirin prescribed lifelong after first PTCA performed from Grunzing in 1977. In 1990s, clopidogrel superior to aspirin in reducing ischemic events and to anticoagulants in reducing bleeding. So DAPT concept was born. In 2001, Cure PCI 12 months DAPT more efficacious than single antiplatelet therapy. And in ESC 2006, DES Firestorm with Kamenzind meta-analysis, where there is a 3.9% absolute increase in mortality for DES versus BMS. So FD and ESC guidelines amended 12 months DAPT post-DES implantation. The switch from placebo to single antiplatelet therapy to dual antiplatelet therapy with clopidogrel first and with more potent P2Y12 inhibitors such as prasugrel and ticagrelor for ACS patients then has significantly reduced the adverse ischemic events following stent implantation, but at the cost of a significant increase in major bleeding rate. Increasing in parallel also the risk of death as shown in the pulmonary meta-analysis. So long-term DAPT after DES placement prevents one stent thrombosis and induces 2.1 more bleeding. So pulmonary et al. Meta-analysis showed an increased mortality rate for non-cardiovascular cause with long DAPT compared to a shortened one. These are 10 PCI trials with around 31,000 patients, 6 months versus 12 months DAPT. Longer DAPT, significant increase in major bleed and death rate. So major bleeding can kill patients for non-cardiac causes without reducing the cardiac death risk, the one that DAPT should prevent. An additional proof was retrospective study made by Dr. Kinyard in 2003. More than 10,000 PCI patients included in retrospective analysis. More than 70% patients died by 1 year after PCI when having a major bleeding event. The remaining patient who survived often experiences reduced quality of life. So, antithrombotic strategies for patients as high bleeding risk who have undergoing percutaneous cardiac interventions, coronary stenting with precise depth more than 25 and ARC HBR more than one major or two minor criteria. If no anticoagulant is required, then 1 to 3 months of depth followed by aspirin alone. And if OAC required, then up to 7 days of triple antithrombotic therapy followed by 3 to 6 months of double antithrombotic therapy, followed by oral anticoagulant alone. If in case of aortic valve replacement, predict tower more than 12 or ARC HBR more than 1 major or 2 minor criteria. If oral anticoagulant not required, then aspirin alone. If and oral anticoagulant required, then OAC alone. And then left atrial appendage occlusion with Hayes blood more than 3 and contraindication to oral anticoagulant or DAPT. If OAC is not required, then 1 month DAPT followed by aspirin alone. Or if oral anticoagulant is required, then OAC alone, or even we can shift to aspirin alone. And in mitral and tricuspid interventions, prohibitive surgical risk, contraindication to OAC or DAPT. If it is not required, then 1 month DAPT and followed by ASA alone, aspirin. And if oral anticoagulant is required, then oral anticoagulant alone or can shift to aspirin also. So impact of abbreviated versus standard DAPT in patient in high bleeding risk undergoing coronary stenting. Less than 3 months DAPT after PCI appears to be a pediatrician in high bleeding risk patient to optimize outcomes. Decreases 20% MCRB, 20% major bleed, 21% cardiovascular death. So aspirin or P2Y12 inhibitors monotherapy after DAPT discontinuation. In HBR patients undergoing PCI, a 1 to 3 months abbreviated DAPT regime was associated with lower bleeding and cardiovascular mortality without increasing ischemic risk compared with a more than 3 months DAPT regime. No difference in bleeding and ischemic protection by continuing single antiplatelet therapy with either aspirin or a P2Y12 receptor blocker was observed, confirming the feasibility of both strategies in HBR patient after an abbreviated DAPT course. So again, a lot of DAPT trials like Reset, Optimize, Global Leader, Glassy, Reduce, Smart Choice from 2009 onwards, and we can see 1 month or 3 months DAPT followed by single antiplatelets. Similarly, stop DAPT and stop 1 and 2. Again, 1 month, 1 to 2 months DAPT. So in conclusion, 2023 ESC guidelines for management of ACS says that aspirin is recommended for all patients without contraindication at an initial loading dose of 150 to 300 mg and a maintenance dose of 75 to 100 milligram OD for long-term treatment, which is a class 1A indication. And in all ACS patients, a P2Y12 inhibitor is recommended in addition to aspirin, giving as an initial loading oral loading dose followed by maintenance dose for 12 months unless there is HBR, again class 1A indication. For antithrombotic therapy in patients who have event-free after 3 to 6 months of DAPT and who do not have high ischemic risk, single antiplatelet therapy, preferably with a P2Y12 receptor inhibitor, should be considered, which is 2A at level A class. And in HBR patients, aspirin or P2Y12 receptor inhibitor monotherapy after 1 month of DAPT be considered, again 2B indication. So to conclude, available data were unable to show superiority of one standard form over another. However, biodegradable non-polymer stents might be safer in an abbreviated DAPT environment. DAPT distribution should be adjusted based on patient characteristics and bleeding rather than ischemic risk should be prioritized in HBR patients. There is no difference in aspirin or P2 after DAPT. Regardless of score used, patient at HBR who received abbreviated 1 month or 3 months of DAPT have a 24% reduction in major or non-clinically relevant bleeding, 20% reduction in major bleeding, and relevant cases. Thank you.
Can you hear me, Mukul?
Yes, sir.
Yeah, very nice, elaborate discussion by Mukul. And there are so many factors. There are so many factors, right from clinical right from clinical factors to the history and the type of stent, approach, and so many. Mukul has gone through all that. So we have to decide. There to guide us. There are so many scores are there which can help us in calculating, anticipating the bleeding risk. And right from approach, history, whether it is high thrombotic or high bleeding risk, and what at least what we can do. But sometimes time is very short, and sometimes we are doing primary angioplasty. We may not be able to see all the causes. Some are occurred, and then the challenge really lies. So there are so many evidence have come, as Mukul has rightly told, that about the stents, polymer-free stents, DCB, radial approach, short duration DAPT. So they can be very intelligently used, and just to minimize the bleeding risk, because bleeding definitely increase mortality. But sometimes the challenge is there when a patient suddenly starts developing hematemesis, and we are not able to anticipate that, and then it is a problem, and then we have to de-escalate our therapy, and we have to do what we can do. Any questions from Ram? And Mukul, have you experienced any patient where you are taken suddenly by, you are surprised that a patient started bleeding, although he was not expected to in emergency cases? He started having hematemesis or intracranial bleeding. So then it becomes really challenging because, yeah,
Patients
there can
with
be hidden.
hematomesis, because in primary angioplasty, sometimes even
Yes,
investigations come after we have done the procedure. So sometimes hemoglobin, sometimes platelets, these are not available beforehand, before doing the procedure.
yeah.
We can, yeah. I have Vivek.
Hi, Mukul.
Yeah,
Great presentation. A lot of effort has been put in this presentation, and you have presented it very well. Just one or two points I would like to make. Yes, you have made a very important point that DAPT or the antiplatelet strategy should be based on the patient characteristics and not on the ischemic risk of the patient to reduce the high bleeding risk. The patient characteristics keep on changing over a period of time. Suppose your patient is having anemia at this point of time, and then he becomes a high bleeding risk because of that criteria. And suppose over a period of time the hemoglobin is corrected. So, would you recommend changing over from the strategy according to the change in the characteristics? Suppose he is having he was started on some drug like sacubitril valsartan, and the creatinine went off, and the EGFR you calculated came down, and then you considered him as a high bleeding risk patient. But then over a period of time, the creatinine normalized, and the EGFR improved above 68 came up with the improvement of creatinine. So, do you think there would be a change in the strategy of the DAPT according to the change in the patient characteristics, or once a decision has been made at the starting, the strategy remains fixed over a period of time?
Actually, this calculator is based on initial or baseline EGFR or baseline HB. So if these are changing or we have corrected those, and so I don't think is also not high, then we can pursue our baseline decision. We can keep on that decision.
Great.
Dr. Ram,
yeah. Hi,
any
Mukul.
comment from Dr. Ram is
Great
there?
presentation. So,
Yes,
one or
sir.
two comments that I am
I
unable to
think Dr.
understand that after a abbreviated DAPT, why aspirin and other TP2 white value inhibitors are similar in maintenance therapy, because aspirin is known to have gastric irritant and causes gastric erosion. Still, trials did not show any difference that on maintenance you can use aspirin or any other P2 white value receptor inhibitor. And if we chose some
Yeah.
P2 white receptor inhibitor on follow-up, then which one among three, like clopidogrel single 75 milligram versus low dose prasugrel versus low dose ticagrelor? So, what is your opinion regarding these two questions?
So basically, trials have similarly, like in stent trial, there was no difference in any of the stents. Similarly, in this trial, whether we use aspirin, clopidogrel, there was no difference, ticagrelor or prasugrel. However, these are like aspirin. These are based on MACE, major adverse cardiovascular effects, and not on minor. So probably aspirin may not be causing as much as bleeding as we think. So there was no difference in MACE in all these 4 drugs.
And which one do you choose after first month of DAPT among 2p2 receptor antagonists?
So we are to continuing mostly with aspirin 75 only.
Okay, you don't go with the clopidogrel 75 OD or low dose of Brilinta 60 milligram BD like that. No,
Mostly in our hospital, our strategy is to use
just
aspirin
75
only
milligram OD.
because that is a cheaper option also. And if
Yeah.
patient says gastric irritation or have some, then we shift to clopivas.
I think there was a study Twilight trial, which was published last year. That
Yes,
gave
sir.
that Brilinta 90 milligram BD should be the single mono antiplatelet therapy after first month of
Yes, sir.
DAPT. Yeah.
Yes, sir.
That was by Roxana Mehran that showed a good results.
Ticos and Twilight. Ticos
Yeah.
also.
Yeah.
So we follow like this DAPT for 1 month or 3 months, and then ticagrelor or monotherapy 90 milligram for first year. And if the patient is high ischemic risk patient and low bleeding risk patient, then ecosprin 75 plus ticagrelor 60 to continue for 3 years according to the Pegasus data. Or if the patient
Yes.
is high bleeding risk patient and high ischemic risk patient, then we do not give ecosprin. We give only ticagrelor 60 milligram twice daily after 1 year. But this is not totally supported by guidelines. This is what I manipulate or I improvise for my patients. So it's my protocol, I would say.
Actually, ESC also in 2024 onwards is suggesting that you give only single P2Y12 receptor and remove the aspirin completely. Because aspirin is supposed to be contributing to the bleeding risk more than P2Y12, it seems.
Many
So they
patients
have
get
included
anemia.
this.
Many patients get anemia
Yeah.
after you start aspirin, and it improves if you stop aspirin.
Is there
Yeah.
a difference in bleeding types? Like I feel that GI bleed or genital or urinary bleed, these are relatively safer. You can try to localize the bleeding site, and if you have localized the bleeding and cut off that, remove that bleeding source, like cautery or not, whatever, the patient is relatively safe compared to cranial bleeds, which are something that I think are real risk. Other than cranial risk, GI or other sources of bleed are relatively safer to manage. So I think it's
IC bleeds, otherwise local site bleeds are relatively low.
In our experience, Mukul, quite a few patients who came for angioplasty and they were loaded
Yes,
after angiography with ticagrelor. I remember 4 or 5 developed intracranial hemorrhage, and they were localized and patient recovered. But in retrospect, there was no high bleeding scenario in those patients. So I have seen ICH with ticagrelor at least 4 or 5 in last 1 year. I don't know what is your experience. And then definitely we have to de-escalate the therapy because we are anticipating. Sometimes we fail to anticipate, and then patient land up like GI bleeding can be very bad. If it is massive GI bleeding, very difficult in that phase of angioplasty, maybe because of occurred peptic ulcer, and very difficult to manage because it failed to respond conservatively, pantoprazole infusion or sucralfate, and very difficult. After 2 or 3 days of angioplasty, patient has massive hematemesis, so it becomes very challenging. And same as for ICH in those patients, whether to stop after 2 days of high risk, that is a proximal LED angioplasty, whether we have to completely stop. So there are so many gray zones, and because the balance is really a art and very difficult art in these scenarios. So I have seen ticagrelor. So maybe I go for clopidogrel. I don't go for that. 30-40% cases I choose to clopidogrel to load, and 50-60% ticagrelor, and less categories prasugrel. But sometimes surprises are always there because we cannot be 100% sure in short period of time about what is the HBR risk in this patient or thrombotic risk in this patient. Anyone to add anything? Everything has been covered very well by Mukul.
Thank you, sir.
Who else is there in this? Is Mukul? Vivek has commented. And Smit,
I just want
think
to
is
ask
still there.
everybody about drug-coated balloon. So, are we using drug-coated balloon really in high bleeding risk patients with proximal artery or main artery lesions?
I'm not using.
So
I mean, I still
Basically,
don't have the confidence actually.
people
which
are nowadays doing in left main also,
Yeah.
proximal LAD also.
They are doing in
And,
left main and they are leaving
No,
big
no, no.
dissections also, and they say that it heals by itself.
Definitely.
I used in couple of LAD proximal LAD lesions where the artery was quite tortuous, and I was scared that the stent would scrape the any plaque and cause dissection. So in a very tortuous artery, I have used in 2-3 patients. That has been 1 year ago. They are alive still.
we have used in small vessels only, less than 3 mm distal
Yeah.
vessels, not in
Small,
proximal ones. And
small vessel or
moreover, cost
ISR
of
or
balloon is
thin
higher
vessel.
than cost of stent. So we have mostly card patients, and in those it is difficult to explain why stenting not done.
so what I'm saying is with drug-coated balloon, we can not always be very confident or switching over to single antiplatelet also, because there is an unpredictability whether the artery will collapse. Like
Yeah.
we might think that we are putting drug-coated balloon and we can get away with single antiplatelet, but the thing is that those
Yeah.
arteries can be thrombotic. We are creating dissections in the intima and leaving it just like
Yeah.
that. So I think whether we can be confident about
Yeah.
using single antiplatelet with drug-coated balloon, maybe we
I
need
think
to
we should
experience.
restrict to small vessel and ISR, thin caliber vessel less than 2.5. We should not use in proximal LAD or big vessel. I don't think they are safe, and their role has come down recently. The hype has come down. The hype which was created by DAB has failed to sustain. We should be very cautious regarding expanding the spectrum of use of DAB.
No, but what has
Limited,
been shown in most
limited.
of the conference is that they do regular check angiograms at regular intervals. That is very difficult in our
Very
scenario to
difficult.
do those things.
Yeah, that is very difficult, impractical. We cannot do angiogram. And one doctor said that he's doing DB in ostial left main. He was from, I think, Turkey. I thought this is highly objectionable. They're doing DB in ostial left main with so much element of recoil and how they assess. Then he answered same that he's doing check angio after 6 months or 1 year, even in asymptomatic patients. So there are no
Yeah,
guidelines and no evidence. I don't think this is ethical also.
So
So DB role is very limited. Distal
I think
vessel, small caliber, or ISR or ostial circumflex. We should stick to this.
what a judicious
And
approach will be.
Mukul is doing same. Mukul is
True.
following same.
Agreeing.
I think what a judicious approach would be that a DB can be used where you desperately need to dilate the artery and you cannot put a stent. So,
Yeah, definitely.
so be it proximal and you want to open it to establish a flow and you
Yeah,
cannot put a
definitely.
stent for
In
some reason,
that scenario,
then you can
you
use
have
it
to establish the flow.
because where you
Yeah.
can do nothing, at least use a DB.
At least you can, yeah, in that scenario, it is justified.
Yes, sir.
So these were wonderful slides, and Mukul has definitely collected a lot of data. So Smith will load, and this is loaded on the PJ website, so others can read. I don't think there is any other query from anyone.
the other day, 5 today.
So there is no other questions, no other query, so we can wind up this presentation with a note of there are a lot of conferences next year, and I hope to meet you in India Live or NIC. Definitely, there is a
Definitely,
reunion
sir.
also planned in April, and we'll meet
Yes, sir.
Mukul. Mukul definitely will come to India Live.
Yes, sir.
Sir,
We'll
Mukul has
Supposed to
100%
get us in.
attendance in conference.
And
Mukul was
last week,
supposed to go invite us.
yeah, Mukul will invite. Mukul already invited. No one.
I
I was
already
ready to
invited them.
come. I will.
Nobody came.
So March, in
I will
March, you
come.
have to organize something in March.
Definitely, I will come. But again, there's a reunion in April, so there will be too many visits. So some in Bay Area, May or June, I will visit Mukul's beautiful city.
Yes, sir.
and we'll meet
Definitely,
in
sir.
India
Most
live and
welcome.
also. Yeah.
Yes,
Okay.
sir.
Bye. Happy New Year
Okay,
to
sir.
all of you. Happy New Year.
Thank
Happy
you,
New
sir.
Happy New
Year.
Year.
Thank you.
Thank you.
Thank
Same.
you. Thank
Good
you.
night.
Good
Okay,
night.
sir.
Good
Night.
night, sir.
Good night. Good night.
Thank you.